How to check the correct position of fiducial markers on the vaginal cuff using transvaginal ultrasound. Fiducial markers have been developed to enhance the precision and accuracy of patient positioning and the delineation of gross tumor or clinical target volumes. They facilitate the use of standardized volumetric EGRT procedures to serve as surrogates for the vaginal vault. Here we present a clinical case of a woman of 87 years old, ECOG 0. She received a diagnosis of FIGO2 low-grade endometrioid adenocarcinoma, poly and P53 negative. She underwent a hysteroanesectomy with bilateral laparoscopic pelvic lymphadenectomy, and the final stage, according to FIGO 2023, was 1B. In relation to the intermediate grade of the disease, exclusive vaginal vault treatment was proposed after placement of fiducial markers. FM were inserted in the vaginal cuff in an outpatient setting after local anesthesia. The technique included each marker was placed on the bevel of a 20 gauge with a 20 cm injection needle and then introduced. Typically, 2 to 3 markers are strategically positioned, one for each vaginal angle and an additional one centrally to the anterior margin of the vagina. At the end, an ultrasound examination to verify the correct placement of the FM is performed. FM into the area of interest are used to measure respiratory-induced tumor motion, to reduce organ movements, and to define the precise boundaries of the malignant disease. The vaginal vault is recognized to be an anatomical area prone to positional variation. Indeed, vagina fluctuates up to 14 mm due to variation in daily bladder and rectal fills between fractions. After the position of FM, it is mandatory to verify the correct placement. For this reason, confirmatory CT scan or MRI are usually performed to ensure accurate insertion closely to the vaginal vault and in proximity to organ at risk. Nevertheless, using an ultrasound scans allows for real-time monitoring, enabling quick verification and, if required, reinsertion. Here we present an easily reproducible standard technique to verify the presence and correct placement of fiducial markers on the vaginal vault before performing planning CT. We will demonstrate the precise placement of the seeds on the vaginal cuff, offering guidance on verifying their position and outline methods to identify and prevent incorrect placement or displacement. Preparation. Transvaginal ultrasound procedure is conducted with the patient in dorsal lithotomy position. Nevertheless, the exam can be done also by transrectal ultrasound. It is recommended that the patient's bladder be either empty or contain a small amount of urine during this examination. In this way, compression of the vaginal dam is alternatively avoided and the structure can be better visualized. Step 1. A longitudinal view of the vaginal vault should be obtained by introducing the probe into the vagina and sliding it lengthwise slowly. The magnification and depth must be set to ensure correct visualization of the vagina in the center, the bladder anteriorly, and the rectum posteriorly. In the mid-longitudinal section, the anterior marker can be seen as a hyperechogenic oval structure. The FM positioning within the thickness of the vaginal wall can be verified by applying pressure with the probe against the vagina. Step 2. Starting with the mid-longitudinal section, a lateral side-to-side movement can be employed to verify the inclusion of the right and the left markers within the vaginal thickness. Additionally, their separation from surrounding organs can be confirmed by assessing their mobility when the probe is pressed against the vagina. Step 3. To obtain a transverse section during transvaginal ultrasound, rotate the probe 90 degrees clockwise while ensuring the vaginal dome remains centered in the image. This transverse section also allows visualization of the markers within the vaginal wall. By moving the probe laterally, first to the left and then to the right, the vaginal angles can be visualized with the FM positioned on the same side. To confirm the correct placement of the marker in the vaginal wall, gently push the probe against the lateral vaginal fornix to observe the sliding sign. This mark indicates sliding and separation of the vaginal and other viscera, confirming correct placement of the marker. Extra caution should be exercised during the implantation of the third and the fourth fiducial marker. Some authors have indeed shown that they are those most at risk of displacement. The optimal geometric arrangement for image-guided radiation therapy involves using at least 3 fiducials spaced more than 2 cm apart, ensuring they are not collinear with the image plane and maintaining an interfiducial angle greater than 15 degrees. FM can be strategically positioned around the perimeter and at the center of the surface to be treated, with their exact placement determined by the size and location of the tumor or the area requiring irradiation. Why choose ultrasound? Echo-guided placement of FM is today standardized in either gastrointestinal and urological oncology. The FM endoscopic ultrasound-guided positioning technique in gastrointestinal tumors has demonstrated a nice success rate between 85 and 100%. Furthermore, the procedure has proven to be safe, with a low incidence of minor complications ranging from 1 to 7%, which typically resolve spontaneously. The dislocation rate was also low, with the possibility of repeating the echo-guided procedure if necessary. The same results were confirmed on a meta-analysis. Transvaginal ultrasound guidance provides comfortable operation, high precision, and excellent safety. It not only improves the accuracy of implant therapy, but also reduces the risk of anesthesia and organ injury, making it well suited for widespread adoption and use. In urological side, ultrasound is the FM insertion gold standard technique for radiotherapy treatment of prostate cancer. Fiducial markers are positioned to guide irradiation, typically using either transrectal or transperineal ultrasound guidance, both of which demonstrate consistently high success rate. In gynecological oncology, the use of ultrasound for fiducial marker positioning is not yet widely practiced or recognized. Several factors may contribute to the limited literature on its application, despite ultrasound being a widely used and diagnostic technique in gynecology. In one of the few published studies on the subject, ultrasound is not mentioned for post-implant proof. Instead, cone-beam computed tomography is identified as the method used for daily adjustment during IGRT. While recognizing the importance and necessity of CT in radiotherapy treatment planning, a simple transvaginal ultrasound without the need for sophisticated equipment allows for early detection and correction of any misalignments or missing prior to performing the planning CT. Checking the correct placement of fiducial markers on the vaginal cuff before starting radiotherapy for gynecological tumors is a straightforward procedure. Our video article demonstrates that the technique does not require highly specialized ultrasound expertise and stands a top-tier method worth considering. Although there is a lack of specific data in the literature on this topic, there is no evidence suggesting contraindication to its use. Therefore, conducting research in this straightforward field could be valuable, potentially by comparing the three modalities: TSV ultrasound, CT, and MRI within the described context.